Hello, everyone, and I want to welcome you to Talking Cancer with Dr. Roman. Now, I am a board-certified hematologist, oncologist, and today's topic is the treatment of CLL or chronic lymphocytic leukemia. Now, I want to warn you, this video is intense. I cover a lot of information, so this is mainly geared for healthcare personnel, doctors, nurse practitioners, physician assistants, medical students, etc. But if you're a patient or a family member and you're gung-ho about learning, I tell you what, I'm going to give you a lot of information in this video. And if I had CLL and I was a patient, believe me, I'd want to know this information. So with that being said, let's get started. Right, so as with all my videos, this is for educational purposes only. I am not providing medical advice. Right, so if you're interested in learning about CLL, I recommend you find the video on your screen right now. It's in my channel where I discuss the details about CLL. In other words, what is it? How do we make the diagnosis? How do we determine prognosis? Do you require treatment, the staging? I mean, everything that I think you need to know about CLL is covered on that video. So I would recommend that you find that video first and you review it, and then you come back to this video, okay? This video is specifically on the treatment of CLL. Right, so let's start off with a brief overview of everything we are going to cover. So the first thing we're going to do is go over the grand majority of medications that we have out there for the treatment of CLL one by one. Then after this, we're going to go over the different treatment combinations. That's at the latter stage of this presentation. Just keep in mind that all medications are potentially good options, okay? And I'm not going to be able to cover every specific detail of every medication. So that's why it's so important that you talk to your doctor about the specific treatment you are receiving. All right, so if you saw my prior video on CLL, you will remember that the first question to ask is, do you require treatment? That's the first question, because a lot of patients, if not the majority of patients with CLL, in the earlier stage will not require treatment. That's right, we are only going to follow you. Now, if you require treatment, just know that we have many potential options and combinations of treatment, okay? So that's the important thing and the reason you really should know the details I'm going to discuss in this video. Now, if you remember from my prior video also, we tend to categorize you, if you have CLL, as low-risk CLL or high-risk CLL. We also take this into consideration. So, for example, if you have a 17P or an 11Q or a TP53, then we consider you higher-risk CLL, and there are some medications that we will prefer over others. And if you don't know what I'm talking about, it's because you did not see my prior video. All right, so let's start off with a group of medications that are called BTK inhibitors. And these are covalent BTK inhibitors, because that's right, we also have a non-covalent, which we are going to talk about later. So the family of covalent BTK inhibitors, first of all, they are taken orally, and they can be taken with or without food. And just know that we have three options, and they are ibrutinib, acalabrutinib, and zanubrutinib. They are all wonderful medications, but there are some side effects, some pros and cons basically that you need to know about this family of medications. All right, now let's move on to the possible side effects or risks of using the covalent BTK inhibitors. So first of all, bleeding might be an issue. Although it's rare, this is not a common occurrence. I've used all of these medications, and I actually do not remember having a patient with a bleed. But just know that bleeding tends to be a little more common with ibrutinib than the other two. And as a general rule, if you have a patient on one of these medications and they are going to go for minor surgery, we usually recommend stopping these medications at least 3 days before minor surgery and at least 7 days before major surgery, okay? Also, something that patients may complain about when they start these medications are a slight increase in the bruising of their skin. So just something to keep in mind, especially if they're taking it together with a blood thinner or aspirin or one of these medications. You also have a slightly higher risk of cardiac arrhythmias. This is also a little more common with ibrutinib than the other two. Also slightly higher risk of high blood pressure or hypertension. Again, a little more common with ibrutinib than the other two. They can all also decrease your blood counts, especially your white blood cells. It's something we call neutropenia. Just know that that one tends to be a little more common with zanubrutinib. Skin cancer can also happen with all of these. So what we usually do is especially if you're on these medications for a long period of time, we will perform periodic skin exams. We'll just look at your skin, make sure that we don't find something abnormal. Just know that this tends to happen when a patient's been on these medications for quite some time. And again, it's not that common. It also has the possibility for liver toxicity. It's not common, but your doctor will monitor your liver enzymes. Also, if it decreases your white blood cells, okay, or your immune system, it can also increase your risk of infections. Again, I can tell you this is rare. I've used all of these medications, and quite frankly, I do not remember the last time I had a major infection. I really don't. And the last one here is diarrhea. Again, it tends to be a little more common with ibrutinib, but again, overall, relatively rare. I can tell you that I've used all of these medications. Overall, I feel quite safe using them, and patients tend to do quite well, and their CLL usually responds quite nicely to these medications. Okay? Right, now let's move on to the non-covalent BTK inhibitor. This is a medication that's called Purtobrutinib, and it's also taken orally. It can be taken with or without food, and it's usually given once one of the covalent BTKs, one of the prior medications, stopped working. Okay, at that time, we may consider treating you with this medication that's called Purtobrutinib. Just know that overall, the side effects tend to be similar to the ones that we went over with the covalent BTKs, the prior three that we were talking about. All right, now let's move into another family of medications that are called BCL2 inhibitors. Now, just know that there are several under development, but there's one that we are using and we've been using for quite some time. It's called Ventoclax. It's also a pill. It's usually given orally once a day. It's taken with food or with a meal. And the neat thing about this medication, or what you have to do, is that we start you at a lower dose and we start escalating the dose weekly. So we'll usually start you on the first week on 20 milligrams, then the second week on 50 milligrams, then 100 milligrams, on week 4, 200 milligrams, and then starting week 5, we will keep you at 400 milligrams once a day if you are tolerating the medication correctly or well. Now, continuing with Ventoclax, the main risk factors or side effects that you need to keep in mind is, first of all, by far this first one, and it's something we call TLS, or tumor lysis syndrome. And what tends to happen is that patients with CLL, if you require treatment, it's because you have a very high white blood cell count and you probably have symptoms or you have very big lymph nodes. Again, all of this is discussed on my prior CLL video. So needless to say, the decision was made that yes, you require treatment. So the problem is that you have likely quite a bit of CLL or SLL, if you remember the prior video, the small lymphocytic lymphoma. So when we start you on Ventoclax, your CLL cells will start to die off rather quickly. This medication works rather quickly, and this will release a lot of toxins into your body. And this can result in an elevation in your uric acid levels, in your potassium levels, and your phosphorus levels, and it can decrease calcium levels. Okay, so all of this can lead to renal failure. It can attack your kidneys. And that's something that we really want to monitor and try to prevent at all costs. So what we do is we aggressively recommend hydration. You have to drink a lot of fluids, especially at the start of Ventoclax. What I usually tell my patients is I really want you drinking a lot and I want you urinating a lot. You really have to monitor your urine output. And as a general rule, if you notice that your urine is very yellow or it's very concentrated, chances are you're not taking in a lot of fluids. So we will monitor your blood tests. And again, we want to make sure your creatinine or your GFR is appropriate, because you are at risk of developing tumor lysis syndrome, and that is toxic to your kidneys. Okay, there are also medications that we can give you that help reduce your uric acid levels. Okay, so also something that your doctor will strongly consider giving you. And this is mainly at the start of treatment. Again, and remember, we start you low and we start going up on the dose every week. Okay, the other risk is neutropenia. Again, a decrease in your white blood cell count, and this could lead to an increase in the rate of infections, and it can also cause diarrhea. I've also treated patients with Ventoclax. We monitor them, especially at the beginning because of the TLS issue, but overall, most patients have tolerated this medication fairly well. All right, so if you're learning something, like the video, subscribe to my channel, and what's most important to me, share the video so that other patients can also benefit from this video. All right, now let's move into another family of medications that we call anti-CD20 monoclonal antibodies. Okay, and there are two that I want to touch up on, and they are rituximab and obinutuzumab. Now, just know that these medications are given in the vein, okay? So they are an intravenous infusion. Your doctors will give them to you slowly because there is a potential risk of an infusion reaction. In other words, an allergic type reaction. So we will give you these medications slowly and we will monitor you to make sure you do not develop an allergic type reaction. Now, because of this possible reaction, we will pre-medicate you, usually with a steroid and sometimes with an H1 blocker like diphenhydramine or Benadryl to try to prevent these allergic reactions from occurring. Just know that these medications do decrease your immune system, so you have a slightly higher risk of developing an infection. Although I can tell you I've been using these medications for years, and I cannot remember the last time a patient developed an overwhelming infection, okay? So thankfully, the risk is quite low, but you have to know about it, and we have to monitor you. Now, there is one possible disease or illness that can happen with these medications, and it is called PML, or progressive multifocal leukoencephalopathy. Luckily, this is very rare. And just to kind of give you an example as to what this is, you've heard of multiple sclerosis. So it's a neurological disorder where you develop demyelination of your CNS tract, or your central nervous system. And that's pretty much what happens here. This is a demyelinating disorder, and it's caused by a virus that's called a JC virus. Now, I can tell you this is extremely rare. How rare? Well, I can tell you I've been giving these medications for years, multiple years, and I don't think I've ever seen a case of PML, thankfully. But definitely something that you need to know about. All right, now something that we call Chemo Imunotherapy. What we do is we combine one of the anti-CD20 antibodies that we just discussed with chemotherapy. For example, the two most common regimens is one that's called FCR, that stands for fludarabine, cyclophosphamide, and rituximab. So in other words, it's two chemotherapy drugs with one anti-CD20 monoclonal antibody, or BR, which is bendamustine with rituximab, again, the anti-CD20 monoclonal antibody. All of these are given through IV infusion, okay? And now remember that I'm giving you the CD20 antibody, which we just discussed. So you're at risk for all of those potential infusion reactions and infection risks, but you're also receiving chemotherapy. And chemotherapy, depending which one, has a lot of side effects. They can decrease your immune system, the nausea, the vomiting. They can damage your bone marrow. Needless to say that, patients with these regimens can develop a lot of side effects. So again, you will see the infusion reactions. You have risks of bone marrow damage, which can lead to acute leukemia. Thankfully, this is very rare, but it is possible. You also have the risks of infection. Again, you're receiving the anti-CD20 and you're also receiving chemotherapy. So it's sort of a double whammy, okay? There are lots of potential side effects. Really depends. The FCR tends to have more side effects in general than the BR. So the top one tends to have more side effects than the bottom one overall. But nowadays, these regimens are used much less frequently than before. So many years ago, we would commonly use these regimens. But now, with the Ventoclax and the BTK inhibitors, we are using these chemo immunotherapy regimens much less often. Now, you also have another family of potential treatment options, which are called the PI3K inhibitors. These are not used as frequently as some of the others, but just know that these are oral pills. There's two of them, duvelisib and idelalisib. And just know that they can be taken with or without food, and these have an increased risk of side effects that in general, you need to know about. And those are an increased risk of fever. So we will monitor you for this. And remember, your doctor wants to make sure your fever is due to this medication and not that you are developing an infection. So it can be a little tricky at times. Also, you have risks of a rash, also diarrhea. And usually the reason for the diarrhea is that these medications can inflame your colon. It's what we call a colitis. So if you're taking one of these and you have a lot of diarrhea, stop the medication and let your doctor know immediately. It also has a risk of liver toxicity, what we call hepatotoxicity. So your doctor will monitor your liver enzymes, in other words, blood tests. It can also decrease your blood counts, okay? So we will monitor your white blood cells, your hemoglobin, your platelet counts, and that's easily done through a simple blood test. And it can also cause inflammation of the lungs, or what we call pneumonitis, okay? And that's it. What's important about this is that if you start to develop shortness of breath or a lot of coughing while you are on one of these medications, immediately let your doctor know, because you may be developing a pneumonitis, okay? So overall, if you're on one of these, your doctor will closely monitor you, and you should know about these potential side effects. All right, now let's move on to treatment options for CLL that we do not use as often, okay? The first one is a medication that's called Lenolyomide, and this is an oral medication. We use it for other illnesses as well. Just know that the big thing about Lenolyomide is that it can cause fetal toxicity. So whether you're a man or a woman of childbearing potential, you have to go through something that's called the REMS program. And basically, you have to give a guarantee that you will not become pregnant or you will not father a child. Okay, it's a huge deal. Okay, and something that, believe me, if you're going to start Lenolyomide, your doctors will let you know. You also have a small but possible risk of blood clots. I can tell you, I've been using Lenolyomide for a long time. I do not remember ever a patient developing a blood clot. But because of this small risk, we usually give you aspirin when you take this medication. It also has the risks of lowering your blood count, so we will monitor your white blood cells, your hemoglobin, your platelets. It can cause diarrhea and many other potential side effects. But as I just mentioned, I've been using this medication for a long time. Sometimes I've had to lower the dose a little bit, but overall patients tolerate it quite well. Another group of medications are steroids, especially one that's called high-dose methylprednisolone. And this is an oral steroid. And as with all steroids, if you take it for a long time, there's a risk for multiple side effects. Number one, you can develop weight gain, retention of water. It's something we call Cushing syndrome or Cushingoid features. You develop a round face, if you will, from all this water retention, the weight gain. You also can develop osteoporosis because long-term steroid use can weaken your bones. It can lead to cataracts. It can lead to muscle loss. I mean, it can increase your blood glucose or cause diabetes. Steroids, you really want to try to avoid steroids long term, okay? You don't want to use steroids long term because of these possible side effects. But just know that steroids do kill off some CLL cells, so it is a potential treatment option. There's also another medication that's called alemtuzumab. We used to use this medication years ago, a little more often, but now we seldom use it. But just know that it is still a treatment option. It is given IV, although sub-Q, it does have an off-label use. And the big thing about this medication is that it really depletes or decreases your immune system. That's the biggie with alemtuzumab. So it lowers your blood counts and it increases your risk of infections. It also you have an increased risk of infusion reactions. Okay, when you're getting the drug, you have a risk of allergic type reactions. So remember, since your risk of infections are quite high with this one, we usually give you prophylaxis. In other words, we give you treatment to try to prevent infections. And the big ones are PCP, okay, which is a type of a protozoan, if you will. So we will usually treat you with a medication called Bactrim, okay, or a sulfa, to reduce the risks of this PCP type pneumonia. and also herpes virus. So we will usually give you acyclovir. All right, so we're almost done, okay? So I need you awake here. We're in the home stretch. So another treatment option, and this is more modern treatment, okay? We don't do it as often, but it's kind of the new kid on the block, and it's called CARTT Therapy. And this is a type of immunotherapy. And what we do with this is that we use your own immune cells to attack the cancer cells or the CLL cells. Okay, so there's a process for doing that that's beyond the scope of this lecture. But the big thing about CAR-T therapy is when you have CAR-T therapy, you can develop something that's called cytokine release syndrome. And basically, at the time that you receive this treatment, you can develop a flu-like illness, flu-like symptoms like fever, fatigue, nausea, vomiting, headaches, joint pain, muscle pain. And needless to say, it can be quite severe, so your doctor will monitor you for this cytokine release syndrome. You can also develop neurological type toxicity. So again, for CAR-T therapy, you will be monitored. You also have a higher risk of secondary malignancies or other type cancers, although this is not as common, but something that you need to know about. And as you know, with all of these drugs, you've noticed the common theme. It can definitely decrease your immune system. One of the last treatment options is what we call an allo stem cell transplant, meaning a bone marrow transplant. And the thing about an allogeneic stem cell transplant is that it is using bone marrow from another human being to use. So it's a big deal. This is a procedure that you need to be in the hospital, usually for quite some time. And it does have quite a bit of morbidity and mortality. But just know that an allogeneic stem cell transplant could potentially be curative. So, an option for you to discuss with your doctor. All right, so now that we covered all these potential treatments, what we usually do, if you need treatment, we will treat you with one of these medications or a combination of them. And it really depends on, remember, going back, do you have high risk CLL? Do you have low risk CLL? So if you have low risk CLL, maybe we will treat you with less treatment. We'll give you less drug. If you have a higher risk CLL, sometimes we'll give you a combination. Again, this is a discussion for you to have with your doctor because you have many options. And I cannot sit here telling you that one is better over the other, okay? It's really a decision to discuss between you and your doctor depending on your CLL and what are your goals and the potential risks and benefits of each potential medication. But in general, just know that one potential option is acalabrutinib by itself with or without obinutuzumab, okay? So you can get the pill by yourself or they can give you the BTK together with an anti-CD20 or zanubrutinib by itself, or maybe ibrutinib alone, or together with rituximab. Again, many combinations depending your needs. Or we can give you a BCL2 inhibitor, again, Ventoclax, that we went over, together with an anti-CD20 like obinutuzumab, or Ventoclax plus acalabrutinib with or without obinutuzumab. Or you can get Ventoclax with ibrutinib, or sometimes we'll give you Ventoclax by itself. Again, many different options. That's what kind of complicates the treatment of CLL because you have many options. But in general, options are good, okay? So have that discussion with your physician. All right, now remember the chemo immunotherapy, the combination of chemotherapy with the anti-CD20 antibodies, that's still an option, but usually we will recommend this treatment if you are less than 65 years of age and you have a low risk CLL, meaning you have IGHV mutated CLL without a 17p or a TP53 mutation. Again, you'd know this if you watch my prior video. But if you fall under this patient population, then chemo immunotherapy are possible treatment options for you. Remember, like the FCR or the bendamustine with an anti-CD20 or obinutuzumab with chlorambucil, just many options out there, okay? All right, so you have CLL and you are on treatment. So what do we do? Well, in general, we, depending on the medication, we will have you on this medication until you progress. In other words, you will continue whatever drug, and the day that it either stops working, meaning you're taking the pill, but your CLL starts to grow again, Or you tell me, you know what? This treatment is making me ill. I'm not tolerating it anymore. Well, usually we will change you to another medication, okay? We will just switch you to something else. Or maybe they gave you a medication for a specific amount of time. For example, maybe they started you on one of these treatments, your CLL decreased and you significantly improved, and then they decided to stop treatment on you, maybe because you're of older age, or maybe because you have multiple comorbidities or illnesses, whatever the reason, okay? And you're doing well, and maybe sometime later, your CLL starts to grow back, and we decide that we need to put you on treatment again, okay? And that's how we make the decision. So if it stops working, obviously we need to change treatment on you. So for example, if you were treated with a BTK inhibitor and you progressed or it stopped working, then maybe we can move you on to Purtobrutinib. Or if you were on the BTK inhibitor and it stopped working, then maybe we can move you into one of the BCL2s like Ventoclax, and vice versa. You know, there's really many options. And once you receive these, then maybe they will move you on to a PI3K inhibitor and or maybe Lenolyomide with or without Rituxan. Again, multiple options. It's very complicated. That's why you need to sit down with your doctor and decide what is the best treatment option for you. All right, so as promised, I told you that I was going to cover a lot of information. But again, if you're watching this, I congratulate you, because that means you are gun-ho. You want to learn. And I love to see patients or healthcare professionals that love to learn. So remember, like, subscribe, check out some of my other videos, and all the best to you.